So I also want to welcome Stephanie is here from Supervisor Ron Roberts' office. Stephanie, thanks for joining us as well today. I think it was a good start to start with behavioral health because now we're going to talk about the state of California in an era of change. So I think we needed that behavioral health discussion to be able to talk about California. So with that, I do want to introduce our moderator for this panel, and we're very lucky to have Alyssa Keefe join us. Alyssa is our Vice President of Federal Regulatory Affairs, and she's responsible for policy development and analysis of federal regulations impacting California hospitals and health systems. And she serves as a liaison between CHA as well as all the federal agencies, including CMS. And if you have any questions about any acronym, Alyssa's your person. She'll tell you all about it. So with that, Alyssa, thank you.
Good morning. Oh, this is good. Well, thank you so much for having me here. It's really such a chore to travel from the East Coast to San Diego and a beautiful destination. The weather has been beautiful. It's wonderful to talk to so many of you. For many of you, I am kind of a voice on the phone. So it's great to reconnect with so many folks I haven't talked to in a while. And if I haven't seen you yet, please pull me aside. I will be here. I don't leave till tomorrow morning. So I'm really thrilled to have you all here. I'm excited about this panel. I am joined by three really distinguished folks in their field. We are definitely in an era of change. And I think their perspectives and what Demetrius asked us to do was really think about what we can do together collaboratively throughout this change. And sometimes I feel like it's just we're all in this together and a little bit of mutual support in light of everything that has continued to come at us from all fronts, whether it be at the federal legislative level, the regulatory level, or at the state legislative or regulatory level. It's a very complex environment in which we're working. I think we would all agree that the attacks of the Affordable Care Act and fundamental changes to entitlement reform will significantly undermine the tremendous progress we have made in the state on coverage. And I think we will all agree that coverage is our top priority. But in thinking about those threats, there's also opportunities to make improvements and thinking about how we do our work together to really care for the patients in our communities, bring them the highest quality care that we can. And in doing so, and we're thinking about how do we go about this in this tremendous environment of change, we've asked each of our panelists, you know, what's keeping them up at night? Where are their priorities? And look for those opportunities and partnerships, both at the state and the federal level. So that's what each of our panelists is going to do today, and then I'll kind of wrap up. But as they're talking, please think about your questions. Where are there opportunities locally for you to partner? Where are there opportunities to engage at the state or federal processes? I just want to take a moment to thank all of you that continually engage in our advocacy at the federal and state level. I have the very distinct privilege of speaking for you at CMS, and with my colleague Ann O'Rourke does so with our delegation. But the only way that we are successful is when you all come in before us and behind us. So we have an opportunity to lead with your messages, but your follow-up and your commitment to your patients and letting your members of Congress and the administration know how you feel about these important programs and how important they are to your community is really key. And so I want to thank you for that. So with that, I want to introduce each of our panelists. Each of them will speak, and then we'll tie it up with some questions at the end. So as you're thinking through each of these presentations, please take an opportunity to jot down a question. I know I will. I'm very excited to hear from them. So first, we're going to have Andy Martinez-Patterson. And just as a reminder, their full bios are in your packets. She's the Director of Government Affairs at the California Primary Care Association and the California Advocates. Really an advocate that has been with the organization quite a long time. Just in the few minutes that we've spoken on the phone and in person today, I'm really excited to hear her presentation. Bill Barcelona It serves as Senior Vice President for Government Affairs at CAPG, which is the National Trade Association of over 250 medical groups and independent practice associations. Each one of these folks is going to tell you a little bit more about their organization. We have the opportunity at CHA to work closely with CAPG as well, both at the state and federal level. And then Brianna Learman is the CEO of the Local Health Plans of California, the association representing all 16 of California's community-based not-for-profit health plans. And again, now we have primary care, physicians, health plans, and then providers in post-acute care here on the panel. So we're really looking forward to hearing from all of you today. And with that, I'm going to turn it over to Andy for our first presentation.
Good morning. Thank you so much for having me here today. I want to start off by saying, right off the top, I was just at a health center strategic planning retreat, and I did my presentation, and one of the board members said, "So is there anything good at all going on? Anything hopeful?" To which you might be surprised, but I was like, absolutely, and I mean that without a doubt, unquestionably. I'm always a glass half full person and believe that when in times of trouble, and it really came out, I saw it at least, really quickly with the Santa Rosa fires, the Northern California fires, that without a moment's notice, everyone jumped to attention and everybody was helping and everyone bonded together and horrible things were happening. But even one of the members of our association said, and her house burnt down, and she was in Europe when it happened. And when we finally got to talk to her on the phone, we asked how she was doing, and she was like, "I'm great. I'm so happy to be back in my community. I needed to be here with them doing this. I feel great about it." Yes, bad things have happened, but the community really rallied together. And that's how I feel about right now. When things get a little bit crazy, especially federally, it's hard to rely on the federal level at this point, but then that just means that we rely more locally on each other, which I never think is a bad thing. When anything bad happens, anytime we rebuild it, we tend to rebuild it in a different way than it had been done before because there's something better that we could find, a new solution. So when there's less, I see folks coming together more creative solutions, more collaboration, of which I'm a huge fan of. And if we have more, we all know how to do more with more and enjoy more and have more services and more providers and more access. But when there's less, we know how to work together. And I don't know that we're going to have less access and less services for our patients. We will just figure out how to share in that responsibility together. And that's a good thing. So from my perspective, it's kind of crazy. It makes life very interesting on a day-to-day basis. But it's only good things that are going to happen. And I'm really excited to be here because I was just asking Demetrius if we'd ever been invited before. And I didn't mean that in a negative way. And he said it wasn't regular. And I was thinking, well, I don't think that we've invited the hospitals to be a keynote at our annual conference for the health centers and the clinics. So I think I appreciate this moment in time, and I think it's important and that we have a lot of work to do together. And hopefully I can share a little bit about what we're going through and who clinics and health centers are in California to help speed up that process of collaboration. So I'll do a little on the federal landscape, a little on the state, and then talk about our policy priorities. But really quickly, I want to note that, so CPCA, the two distinctions. So CPCA is the California Primary Care Association. We're the trade association for nonprofit community clinics and health centers. There's about 1,300 across the state serving 6.5 million patients, about 1 in 6 million Californians, which is amazing if it meant that these were all people who, by raising their hand looking for a health center, came to us. Unfortunately, it usually means that that's how many low-income people we have in the state. We serve 80%, 85%, under 200% of federal poverty. But still an amazing network. In clinics, as you know, I'm sure most of you work with them, at least federally qualified health centers operate under this idea and a theory of comprehensive health care that started way back in the early 60s. And it's wraparound services, it's culturally competent, it's in the community, for the community, by the community. So really proud of that. And just to note that in 2015, we spun off a C4, so that's the name that Alyssa was mentioning, California Health Plus Advocates. And that's our C4 so that we can continue to do more and better advocacy. And the reason you might say, what is California Health Plus, and why would you choose that name? I know it's still confusing in the capital a little bit. But in 2014, pre-2014, knowing that the ACA was coming, the association, CPCA, decided in the health centers that we needed a brand, that competition was going to become more more prevalent, and so we needed to be recognized by something. Who are we at the bigger level? So that's what you will see with California Health Plus. If you ever see a health center that has a California Health Plus center, that's the brand that we built with all the health centers, and we wanted it as part of the C4, mainly because of that idea of what the plus stands for. And as an association, we have often been known to be in the building talking about money. Maybe the hospitals do the same thing. We talk a lot about money. We need more money to do more good things. We need more money for more providers. And that started to become who we were, but it's not really foundational to why health centers started to begin with. We started because we wanted to make people's lives better. We wanted wellness in communities. We want to uplift people out of poverty. And that's why we brought in the plus, because it's about the extra things that health centers do, the belief in community health, public health, and that's what we're trying to broaden our advocacy around what we're doing, and you'll see that in our policy priorities. So what's really fascinating is that this is the wrong PowerPoint. It's one, that's why I'm confused by it. It's great. So this is one I gave to the clinics earlier. This is way more detailed than you want to know about. Let's see if so we'll start with, I'm going to just ad-lib it up here. Okay, let's do it. Apologies for that. This is going to make it more interesting for you. So, like you, right, the Affordable Care Act is, the repeal of the Affordable Care Act has been our #1 mission. I have never worked so much on federal policy in my entire life as this year. I'm assuming most of you have never paid as much attention as you have this year. And CHIP reauthorization, as we know, we're having, actually right now in Sacramento, there's a big press conference for CHIP reauthorization and health center funding. The health centers, community FQHCs receive a Section 330 grant. It's about $5.1 billion for all health centers nationally. They did not renew it come September 30th. They did not renew CHIP funding come September 30th. They did not renew health workforce, National Health Service Corps. Teaching health centers was extended to December, but we have all of these cliffs, and not because Congress doesn't like health centers. We have bipartisan support, but as we know, they just can't agree on how to do things at the moment. So we're caught up in this cliff. If they do not refund it, health centers, FQHCs, the ones that you work with, are facing $417 million loss this year. And inevitably, we're trying to be really careful about how we talk about it. We don't want our staff to totally freak out. So you will actually not see a lot of health centers saying very much about it, because we don't want to create pandemonium and we don't want to create an unstable environment. But it's serious. $417 million to the health center safety net is a tremendous amount of money. I want to say I'm very confident that it's going to happen, but it's really hard to know with this Congress. We believe it will be wrapped up in the package for disaster relief. God help us, it does not get caught up in the wall debate. We don't know where that's going to go at all. CHIP funding is in there too. The House has reauthorized 5 years, 2 years for the health center funding cliff as well, and that's also for the workforce. So we have a huge workforce crisis in California. I'm sure you're feeling it as well. We did a report that was about 8,000 primary care providers short. I just saw something from UHW SEIU that it's 500,000 allied workers short in 10 years. Something just astronomical, or maybe it was 50, sorry, 500, so it feels like a lot. 50,000, it was a huge number. And we've been focused a lot on it. So to have no resources for National Health Service Corps, which is grant loan repayment for individuals who spend time in a community health center, if that doesn't get refunded, we're going to be in a lot of trouble, especially rural areas that have a really, really hard time recruiting providers. And then also the teaching health centers. I don't know if you are familiar with the model, but this is the idea, which I believe is complementary to yours, but we know that in order to we love the idea of growing your own. So health centers that can build up medical residencies in their own health centers, affiliated with the hospital, of course, but when they work at the health center, they tend to come back and stay at the health center and stay at that community, and we want to see more of those. And that funding will be going over the cliff January 1 officially. So that's been terribly concerning for us, and all the advocacy in the world can't seem to move the needle on this one. And just in relationship to Affordable Care Act, ACA and CHIP, anything that touches Medicaid touches community health centers, straight out. It's about 60% now, I think, of our patients and about 65% of all of our encounters. And as you might know, Medicaid, when FQHCs see a Medicaid patient, they receive the PPS rate. So it's the more comprehensive rate that pays for the actual cost of the services and the wraparound services that we provide. So it's a very serious issue for us when they either they want to cut services, they want to cut who's eligible for Medicaid, and if they want to move over to a per capita cap or a block grant, which inevitably will likely mean in California less people are covered, and that it just threatens the way that we are able to operate. And then also I just really want to mention that we have been stalwart supporters of Planned Parenthood and reproductive rights, and you might have caught in the debate that Congress wanted to take money away from Planned Parenthood and give it to FQHCs, as that would be the provider that would deliver all the care. And we came out really strongly that FQHCs, health centers, cannot absorb 800,000 visits. And also that patients have a choice, and they should always have a choice, and that Planned Parenthood is an essential provider in our community. So we've been really standing with them on that. And then, of course, immigration. We are big immigration rights activists among the health centers, and so we've been fighting really hard. We employ immigrants, we employ DACA, we employ Dreamers, we employ all of these people, and we serve them, and it's been really terrible in all of the communities in California what's going on with immigration. So let's see what's the next one. Okay, this is not what I want to talk about. Well, this is just one, just so you can see the number of health centers, teaching health centers, 59 of them, and we have, I think, 6 in California. We've got a number, we've been trying to expand this in California. We have a number of health centers that are really interested in starting this program, which we will likely be able to do if the feds reauthorize the money, because we also at the state level have $100 million in residency, of which some of that will go to support teaching health centers. And then 742 residents are supported by the National Health Service Corps. Okay. So this is so interesting to do a PowerPoint that I was not planning to do. So again, workforce is definitely part of our priority. I will just say generally what our priorities are at the state level. Workforce, so $100 million in residency, which we got 2 years ago. Then the governor last year said, meh, we have a lot of funding holes, we're not going to fund it. And then we fought for it again, so we got it reauthorized. We have $33 million coming out this next year. We believe that that $100 million will be threatened again, and that we will have to keep fighting for it because the state will continue to feel unstable with what's going on federally. That remains a major area of concern for us. 340B, which we are partnering very closely with you, actually the CHA as well as the Public Hospitals Association, we're working really closely on 340B. This one makes me very nervous. I'd be curious to hear how other folks feel about this one. I know you're in the midst of a legal battle as well as a new bill in Congress to stop that cut from going through on hospitals that didn't impact health centers. This is a tremendous program for health centers in California. If we lose 340B, share the savings that we accrue from 340B in managed care, we will be in a load of hurt, millions of dollars of hurt. We haven't wanted to quantify it intentionally so that the legislature and DHCS don't understand how much there is at stake. But it's a lot of money, and we are very seriously working with the hospitals to make sure that we can maintain benefit to 340B contract pharmacies and managed care. Behavioral health workforce, we just were able to, behavioral health is just a huge issue for us generally. The mild, moderate specialty continuum is very weird. It's weird to operate. The silos between county and managed care are really challenging. We just worked through a bill to carve out and allow FQHCs to be able to do more on the continuum and to be able to do it clearly and cleanly in accordance with how we're paid for Medicaid, as I mentioned earlier. And we also will be adding MFTs to our workforce as a billable provider. We're very interested in expanding the continuum of care. And I've actually, if you ask our members, when we did we do a process called policy prioritization every year to hear from health centers directly What is it that you want us to be working on? What would make your life easier if we were able to do something with legislation? And inevitably, they bring up same-day billing. I'm sure you've heard this. Health centers cannot bill for a medical visit and a behavioral health visit on the same day, and it really inhibits the ability to do comprehensive behavioral health care. And I've heard that there's interest, and even from our hospital partners, that they want health centers to be able to do this, that this would be very helpful for the system. I'm not promising anything, but it's possible that we might try to bring this one back. But I will say, I think we've tried it 3 times and gotten, I don't know if we've been vetoed 3 times, threatened with a veto, but we've definitely been vetoed on this one. The department is not a fan of this bill by any stretch, but hopefully maybe with the opioid epidemic and our rising acknowledgement that the brain is part of the body, that we have to acknowledge this, and that we, and the department really believes that health centers should be able to do this. It should be built into the payment structure as it is. And conceptually, if you did some math, it might be possible, but if it were possible, then health centers would be doing it, and they're simply not doing it. They cannot make it financially work. So there has to be a different way of approaching this. So we're definitely interested in figuring out how do we further integrate the system, and how do we break down more of those silos. And then what's here also is care coordination. So we, as part of our larger policy priorities, we're really interested in moving outside. And I think I've been at CPCA for 10 years in January. And in the last 4 years, I really feel like we have moved out of, and I'm sure you acknowledge this, right? So when you go to someone else's conference, you realize that the world is not just hospitals. It takes, for some reason, you know this intellectually, but you go somewhere else and you go, wow, it's really not just about hospitals. And in the last 4 years, we've started to really break out of just being about clinics. And I think the healthcare system has been just really siloed because we were able to be very siloed. We didn't have to be working as closely together. And then movements into the ACA really forced more collaboration. And it's made us really have to look at what can and can't we do and what's inhibiting us. And the health home demonstration that probably is rolling out in July, I still feel astonished by this. Hopefully hospitals are involved in this as well. The health home pilots will be an amazing opportunity to do this extra layer of care coordination, which health centers are not paid to do. And we're very interested in finding all of these avenues to have health centers really help link the patient further into that next spectrum of care, that extra case management services, those extra. So the care coordination, Dr. Panbill, is one of our attempts to help ensure that health centers are not prohibited from participating in these really innovative models, to get them to do that, not because they want to do the extra layer, but to allow them financially to be able to do that. And we're also really interested, I mentioned all of these before, I'm not going to mention county contracting, but social determinants of health. So we haven't quite hit the nail on the head on how we are going to do this. I would love to hear more from the hospitals if you're thinking about this as well. Social determinants of health is something we really want to be moving into. It feels imperative, a moral imperative that we really start thinking about it, but it feels ginormous, right? To end poverty just feels impossible, and when you kind of throw that out on somebody, like housing somebody, when you're a healthcare provider, just feels impossible, but you know that they have a problem with the situation, and then it's making controlling their diabetes almost impossible. So how can, and this is really an interesting space for managed care plans, for providers, for hospitals, for counties, for all of us to think about, how are we working together? The way that we're working on it at the moment is just trying to find, because when we talk to our own members, they'll say, I don't have the money to do it. I don't know how to make this one work. I don't have the staff to be able to follow through on the follow-up that patient needs. So we're working with Assemblymember Bloom on a sugar-sweetened beverage fee, soda tax, just to find, regardless of your politics on a soda tax. I really like Diet Coke, so I'm fine to pay extra money to drink a Diet Coke if it helps. But to find some extra resources, tiny little bits, to make a really big pot, to find innovative ways of helping us all work together to help address social determinants of health, of course, with the patients in mind. So I mentioned this, these are our policy, the highlights, our focus is coverage and access, innovative financial models, so we're spending a lot of time continuing to think about how do we move health centers into a capitation model. If you're interested in that, we can talk about more later. It's not moving exactly forward as we had planned originally, but we continue to move it forward. Continuing to integrate not only primary and behavioral, but also oral health care is a really big priority for us. Breaking through the silos across the systems in behavioral health specifically. Doing the extra support services that we mentioned, and then really interested in really continuing to work with the plans on pay for performance and shared savings. And then as I mentioned, a lot of things in workforce. I'm sure you probably have your own issues. Our CFOs have a lot of problem with DHCS and audits and investigations, so that is a huge amount of time that we spend with the department working on fair policies with the department on payment. And then of course, social determinants of health. So the last thing, so again, just to conclude, what keeps me up at night? I think it does not keep me up at night. It makes me, I would say it doesn't keep me up at night with anxiety. It keeps me up at night with how do you tackle really big problems? I think how do we all come together and better integrate is a fascinating question. It's not an anxiety. I'm not scared of it by any stretch. But it's fascinating because we did a lot of work with Sutter specifically to try, because that seemed to be an area that a lot of our health centers were working with the Sutter Hospital to do things on reduction of inpatient hospitalization, putting case managers in ERs, doing a lot of different innovative models, but we struggled to find a lot of hospital partnerships. And it wasn't across all the Sutters. It seemed to be all over the place and different in each place. And I would be really interested on the collaboration question. You know, from your perspective, why haven't we collaborated more? I think I always just assumed, of course, why wouldn't, if the hospitals had all these high utilizers, or wouldn't they want the primary care provider to, you know, wouldn't they say, you know, maybe if as a doctor at the hospital, you'd say, why can't you control your patient? Why are they always showing, you know, like, wouldn't these conversations be taking place? And maybe the primary care doctor would say, why didn't you call me when they showed up at the ER? But it doesn't happen that way. And so is there another body? Should the managed care plans come in and run some data and say, here are your patients you share together? You should be working together. Does it really require more money, or is it really more of is it a systems issue? I think there's a huge willingness among clinics and health centers across the state to better partner. From what I have learned through all of our payment reform work, when we were trying to work with the managed care plans, there was just a lot of not knowing, and I suppose naiveness on, well, who do we talk? I don't even know who I would reach out to, or who's the right person over there to do it with. And that, just starting to break through those really simple barriers, I think has improved our relationships with managed care plans. And I'd be curious if even some of that, it would be as simple as that with some of the hospitals. But I would just say to you all that we are interested in being more integrated with the hospitals and would love to find some innovative partnerships. And at the state level would be happy to facilitate those conversations, but know that they need to happen locally. So with that, I will end my presentation and pass it over to Bill. Thank you.
Thank you, Andy. Good morning, everybody. Hi, I'm Bill Barcelona. I work for CAPG, soon to be known as America's Physician Groups, on January the 5th. So let's talk a little bit about CAPG. I think it's an important lesson in what's going on in American healthcare. And then we'll talk about threats and opportunities, and we'll wrap it up within the 20-minute deadline, for sure. All right. Our mission at CAPG, to assist accountable physician groups and improve the quality and value of healthcare, and to represent those physician groups across the United States and assume responsibility for clinically integrated, comprehensive, and coordinated healthcare. And of course, the byword for CAPG groups has always been the acceptance of risk-based capitated payment. That's been our distinguishing characteristic here in California, and now more so across the United States. We have a small staff at CAPG. We're a small organization based in Los Angeles. We have offices in Sacramento and Washington, D.C. We focus on these three areas: education, advocacy, and leadership. And a funny thing happened after the Affordable Care Act. We came back from Washington, D.C. after the Affordable Care Act was passed in early 2010, and we started getting a lot of calls from physician groups and integrated systems across the United States. And suddenly, we have ended up in 44 states, Puerto Rico and Washington, D.C., and we now have over 305 members as of last week. The trajectory was interesting. We started out in 2014 picking up a few very leading systems, mostly integrated systems. The Permanente groups came on board across the United States, WellMed, which is a multi-state organization in Texas, Florida, California. Everett Clinic up in Washington, very distinguished group. Picked up a lot of groups in Puerto Rico, which was interesting. And then in 2015, we doubled. We picked up Catholic Health Initiatives, which gave us 21 states. We got the Austin Regional Clinic, New West Physicians in Colorado, which is really a very innovative group, and we picked up the Tenet physician groups as well across the U.S. And then in 2016, we tripled. We really started to consolidate our presence along the West Coast in California, Oregon, and Washington, Colorado. We made inroads into Arizona and Nevada, and started picking up groups on the East Coast. And in 2017, we just continued that with larger and larger groups. We got Agilon, Primed, just any number of interesting. And here we are today. We have a huge number of integrated systems across the United States. And it's been a very interesting ride. And I think what it shows is that there is an interest, there is a thirst out there among integrated systems and physician groups to move into accountable, risk-based, contracted models and to emulate what's been accomplished in California over the past 30 years. And I think that's positive. I think that's a sign that providers across the United States are looking for a new way to deliver care, a more accountable way, a more responsible way. And no matter what happens with repeal and replace, I think that at least on the provider side, we're moving forward. So on that positive note, let me turn to the darker side and talk about some threats. So much like Andy, I suffer from PTSD for the past several months. And what I've seen, I've been with CAPG now for 13 years, and before that I did a 5-year stint with the DMHC when it was first formed. And I've seen tremendous evolution of the players, the major players in California healthcare. Obviously, we've all seen the consolidation and the transformation that's occurred. For example, if you looked at the top 25 list of physician groups by enrollment in 2002, they were all commercial and Medicare Advantage. If you look at it today, more than half the list represent groups that solely provide services in Medi-Cal managed care. It's astonishing how things have changed. And it's astonishing how independent physician groups have merged into integrated systems in just the past 7 years, and how the CAPG board table has changed from large independent physician groups to a representation of nearly every integrated health system in California and in other states as well. So here's where we are. The groups are funded through 3 main payer sources: commercial HMO, Medicare Advantage, and Medi-Cal managed care. And a balance of payers is necessary and important when you're operating in a risk-based environment to balance off the low rates and tremendous variation of Medi-Cal managed care with the rapidly declining commercial HMO enrollment. So just a couple of things. We are now at half the commercial HMO enrollment that we were 10 years ago. It is evaporating rapidly. In fact, probably during breakfast, we probably lost another 1,000 lives. It's really staggering how quickly the fully insured Knox-Keene commercial HMO model is just evaporating in California and moving to the self-funded payer model. And Dietmar and I are seeing some really interesting legislation evolve in Sacramento between that system and the Knox-Keene system that's very troubling to us. Medicare Advantage, as many of you know, has been a tremendous success story for the groups and integrated systems in California, and really has provided the foundation for all the development of coordinated care and innovation in this segment of the market for healthcare delivery. And then Medi-Cal managed care. We've struggled, obviously, that we've had a doubling of the enrollment in the groups, and we've had a very interesting blending of the delivery systems over the past few years since the Affordable Care Act. I mean, for example, we have a lot of IPAs now in the Medi-Cal managed care space that are IPAs for Andy's clinics. We have Healthcare LA, which is an IPA in Los Angeles that has over 200,000 lives, that is made up of 200 clinics. We have MSOs that have large clinic consortiums as clients. We have Altimed on our board, which is a very large, well-developed clinic system in LA. And so there's a blending of the delivery systems between what were independent provider groups and integrated systems with hospitals, and on the other hand, IPA models that are incorporating the primary care abilities and capabilities of the FQHC model. So it's an interesting time, and I think the message there is we are learning to work together to solve some of these problems and to figure out models that work for everyone. But we have a lot of administrative burdens, and I've listed a lot of things that keep me up at night. Provider directory reporting has been the unfortunate task for me for the last 2 years, figuring out how we comply with SB 137, how we get accurate provider lists that are sometimes in California as much as 40% inaccurate. We've had some good success with a model that we've developed through a vendor called Gain Healthcare, and we're looking to get that solidified now through the Provider Directory Collaborative that's being developed under the supervision of DMHC. Timely access, language assistance, continuity of care requirements in Medi-Cal, continuity of care requirements in Medicare Advantage, which are somewhat undermining closed capitated networks in the MA space. RBO financial reporting, we're looking at a regulation coming out this December that will tighten up those regulations and increase administrative oversight. Basically, the bottom line on all these is that physician groups are being hit every year with more and more administrative requirements to produce data to a number of payers, and it is getting extremely challenging to balance the cost of those administrative burdens against the cost of simply delivering better care, and doing that in a risk-based model. And so the theme for CAPG in Sacramento for the past year and for the next couple of years is going to be to educate policymakers on the absolute need for administrative simplification. We started out in 2015 with a letter to Director Shelley Riard at DMHC on the Anthem Blue Shield undertakings that were pending in their merger discussions, and we advocated for the use of the undertaking pools to create better infrastructure, electronic infrastructure that was common, automated, and simplified in the areas of provider directory reporting, encounter data reporting, and even with respect to the exchange, electronic tracking of patient deductibles and high deductible models. The department listened and has done tremendous work out of the gate on provider directory utility development. We think we'll have a multi-state online provider directory up and running by the end of 2018. We've been less successful in terms of solving the problems around inaccuracy and encounter data thus far, but we're working on it. And Lately, we've had to add timely access compliance to the list as well, which is a tough nut to crack. But the bywords are automation, affordability, and common electronic infrastructure. And I think what we've proven with the provider directory utility is that, you know, at $5 per unique physician per year, we can provide a single portal where physicians and physician groups can report their information. The portal handles the reporting out to all the different plans in whatever format the plans need, according to whatever business process they need. And it greatly simplifies and increases the accuracy of the data that's being exchanged between the provider community and the plan community to produce more effective lists. And, you know, it's not always understood how important it is that we have accurate provider lists. Everything flows from an accurate provider directory. You can't do value-based payment. You can't do quality measurement. Patients cannot navigate the system without accurate provider directories. And you can't evaluate network adequacy. And we've been living in this kind of fog for decades. And it needs to be solved now so we can move on to some of the bigger tasks of that transition to value-based payment require. So we think we can do that in the encounter data and timely access spaces as well, and that's our task for the next few years. In Medi-Cal managed care, our biggest concern, of course, is what Andy was relating. The loss of expansion funding could be devastating for all of us. Since CAPG groups are increasingly handling duals, vulnerable SPD populations under risk-based models with Medicaid managed care plans, any variation in payment is potentially disastrous for our groups. And so we spend a lot of time back in DC trying to read the tea leaves and stay on top of where things are headed. And we may be headed for a per capita cap or a block grant model. It seems that each time the repeal and replace threat comes up, it's been beaten back, but it keeps coming up and coming up again. It's like whack-a-mole. You know, you hit one head and another one pops up somewhere else. And so I think in terms of it's prudent for us to think about what the world might look like in a per capita cap or block grant model in California and how we might function. We've had a lot of variability in payment in the Medicaid space over the past 10 years. A lot of groups deal with lowered capitation rates once, twice, sometimes even 3 times in the span of 1 year. It is a tremendously chaotic space and a space where you have increasingly sicker and sicker patients, especially with duals. And so stability, even at lower rates, is the preferred state that we're looking for because that's how groups have handled risk in the Medicare Advantage space for over a decade and performed very well. We need greater alignment of incentives between providers and plans in the Medicaid space. Again, Medicare Advantage provides a great historical example of how that can be done successfully. We need to build more infrastructure in the delegated model groups. There's always a problem in Medi-Cal with obtaining funding for privately owned provider groups as opposed to public nonprofit provider side. And the infrastructure in the delegated model group in California that deals with Medi-Cal is old, creaking, needs to be updated, and there has not been a lot of funding for that, but we need some help in that regard. And mostly groups that have a strong Medicare Advantage presence have supplied the infrastructure that's worked for care coordination and risk-based management thus far, but a lot of groups don't have that, and so that's where we fall short. And then let's talk about opportunities. What we've seen since the Affordable Care Act, we worked diligently during the formation of the Affordable Care Act on the ACO provisions in Section 3200 of the Act. we were very, very interested in where that would go, and it's been a rocky road. These programs don't always materialize as you expect. The lack of direct patient attribution was a problem for our members. They're used to that in the managed care model with HMO, and we didn't have that. Data was sometimes 6 to 9 months behind coming out of CMS, so it's very difficult to manage populations effectively. Improvements have happened, and now we're in the next gen phase, and it's getting better. And so I think groups are learning to live outside of the capitated, delegated HMO model and learning to live in this ACO environment a little bit more effectively. And there's been great growth on the commercial side in terms of collaboration between our groups and plans, trying to develop PPO models in the commercial space and even in the self-funded space as well. And then along the way, MACRA came along, and I don't want to talk about MACRA. I don't want to bore you with MACRA. I'll just tell you my boss says it's the most important legislation that's ever occurred in the history of the U.S. Congress, and leave it at that, okay? So remember that. And next time you see him, mention that, please. So we've seen some pretty interesting developments here in just the last few weeks. We have been lobbying for two things in Washington, D.C. around MACRA and ACOs. One, we have advanced a model called the third option, which I'll talk about more, which is a capitated ACO in the Medicare space. We've had some legislation in the Congress in both houses. It has lapsed, it needs to be renewed, but we're seeing some interest on the Republican side to move legislation that would enable that model. And then recently we just had some good news in DC, I think in the last 10 days, that there would be, CMS has authorized a demonstration for APMs that can rely on Medicare Advantage enrollment to meet the required thresholds. And of course, that is going to bolster our IPAs tremendously in California and some of the other states, and I think will advance the value-based movement across the country. And that was a tremendous positive for us just recently. So maybe my boss would say that was the most important thing that's happened in American healthcare in the last 10 days. I don't know, so we'll see. Where we want to go, of course, is globally capped ACOs, and I'll talk more about that. But we think that organizing the different elements of the delivery system, clinics, hospitals, doctors, putting them under a single capitated model, figuring out a governance model that works for everyone. It's a pretty lofty goal, but it develops the kind of delivery systems that we need to address social determinants of health, to address behavioral integration, the things that we absolutely need to focus on over the next 10 years to improve the health status of Americans. And we hope that that's somewhere that we can get quickly. So, more about our third option proposal for ACOs. We submitted this back, I think it was 2013, 2014. If you look at the spectrum in Medicare, on the left hand you see Part A, Part B. It's always been a fragmented delivery model, fee-for-service based. Now it's going to be controlled by MIPS, depending, of course, what CMS does with MIPS. MIPS is a form of MACRA. That's really all you need to know. And then Medicare Advantage on the right-hand side is a very well-organized HMO model, very aligned between plans and providers, ruthlessly administered by CMS with the 5-star payment and quality program that drives a tremendous amount of innovation and alignment between the delivery and the financing model. And it's known for very advanced capitation in California, produces tremendous efficiencies and very high levels of patient satisfaction, good outcomes. So in the middle, what we've proposed as a better model for ACOs is the third option. The entities would be organized like closed system delivery systems in Medicare Advantage. But of course, you can't be closed in traditional Medicare. You have to allow patients to go wherever they want to go. That's been a characteristic of ACOs. And as many of us know, that's a really easy thing to do. You can herd cats, and the way you herd cats is you move their food. And that's kind of what ACOs are supposed to be doing. I got that from somebody else in DC last week. I like that. We're proposing that it be capitated, and we're proposing that it also be incorporated into the APM side of MACRA, and it be recognized as a model where an ACO can obtain voluntarily self-assigned Medicare members, but still under Part B, not Medicare Advantage. And we're hoping that this can provide the right chassis for us to use the techniques that we've developed in Medicare Advantage groups to better control spend and to better coordinate care across the spectrum. So, as I say, we keep touting that to CMMI. We hope CMMI continues to exist and that they hear us and adopt our model. In Medicaid, we're advocating for the globally capitated delivery model in California Medicaid, hopefully under the next waiver. And really, we've looked north to Oregon for a model and have been tremendously impressed with our groups and plans that have developed the CCO model across Oregon. There's 16 or 17 of them. They have been self-organized, built from the ground up. They take global capitation. They haven't exactly been successful thus far in filtering the capitated risk-based model down into the provider community, but they have survived, and they have continued to build a better delivery model at the community level to address social determinants of health, to build better capabilities for data exchange. They are succeeding on many, many levels. And Oregon is a scrappy little state with 4 million people, and they should be very proud of what they're accomplishing in this regard. We think it's a good model for California. California Medicaid has traditionally been very divisive, has pitted hospitals, doctors, and clinics against one another to fight over the table scraps of funding. And if we reach a space where the federal government imposes block grants or per capita caps, we are all going to have to learn to live under a fixed payment model. And that's going to require the sort of structure that Oregon has, where providers self-organize, figure out governance between themselves, figure out a way to make it work between the need to control costs, but keep heads in beds, and to coordinate between the primary care capabilities of clinics and the specialty capabilities of groups in better alignment with hospitals so that everyone survives and patients get the care that they need when they need it. So that's our pitch, and it is kind of a kumbaya approach, I'll grant you that, but I haven't heard anything better out there yet. And then lastly, in the commercial space, to achieve this balance in the capitated groups, we have to expand our membership into the self-funded model. Non-Kaiser, our groups are down to 3.5 million lives in the commercially capitated, fully insured model in California. We had 10 million non-Kaiser lives a decade ago. There are now 8 million lives in self-funded employer models in California. The Knox-Keene Act prohibits our groups from taking capitated payment in the self-funded model, but a lot of our groups have worked in gain-sharing models, in direct contracting with plans, employer self-funded plans, union trust funds. And this, if we can accomplish some legislative tweaking over the next year, we hope to get our groups into the self-funded market in risk-based payment models with self-funded employer plans and union trust funds to balance this loss of fully insured HMO. So that's, in a nutshell, those are the three areas that we're trying to maintain balance in for the capitated model. And that is all I have to say. Thank you very much.
Well, I love irony. So I will point out that it's only fitting, Bill, that you went over time a very little bit. And on the last slide, you're cutting out the health plan, and you cut out the health plan a little bit in your slides. So I think that's a little funny, a little ironic. Good transition. Good morning. I'm Brianna Lehrman, the CEO of the Local Health Plans of California, as it says on the slide. So change is the topic, and of course, I'm going to talk about change from many different perspectives, and I think the presenters before me touched on what change has meant in many ways, and so I'll touch on those as well. I won't repeat too much of what they said. I'll try not to. But I would just comment that, you know, in the last several months, it's felt like change has meant absolute crisis and catastrophe in the context of repeal and replace. But what I'm going to talk about a bit in my presentation to you, and hopefully a conversation with you, is how change has meant, and like Bill is talking about, and Andy, change has meant tremendous transformation and success and growth. So we need to talk about that as well. And while we can't brush crisis under the rug, we can't dwell at it only. I think when we talk about what plans are working on and focusing on, it's felt so much like in the last year that we have been in crisis mode addressing what may happen from the national landscape and hitting California. But we all, like you, have to continue functioning. And we have to continue in our missions of delivering care to those people that we cover. So with that, of course, we can't talk about change without talking about change in sources of coverage and the shifting in the marketplace. So you've seen earlier, acknowledgments about the shift in the market. So this is a snapshot of the market today, close to it. September 26th, I think the data might be from late 2015, so it's a little out of date, but the perspective is the same, it's accurate. And I'll call out just for comparison's sake. So of course, the absolute biggest gains that have been made, and I'm gonna hold Medi-Cal aside for a moment, is individual and ASO self-insured. And we've seen a contracting, actually, of small group and large group. Individual was 1.5 million just before the ACA, growing just shy of double to 2.3, not quite double. By comparison, small group enrollment was 2.3 million just before the ACA expansion, and large group was actually a little over 10 million, so it's decreased. ASO was at just about 5.5 million prior to the ACA, and of course now you see we're at 6.6 million. So we're seeing some shifts and tilts in the marketplace. And of course, looking there at the big orange bar, we had just about, I think, 7 million, just under 7 million in Medi-Cal just before the ACA, and we have had tremendous growth. 10.3 is actually closer, I think, to about 10.6 now, and that's just the number enrolled in managed care. That doesn't include those, the small slice of the population that's over in fee-for-service. So we've seen just an unbelievable growth and shift and tilting of the marketplace. So of course, being from local health plans, and I will tell you who we are in a minute, but I like to give some context first. We're talking about Medi-Cal managed care, and with Andy and Bill before me, they talked, of course, about Medi-Cal managed care. Today, as you see there, we have 23 health plans in all 58 counties. Recall just a few years ago, we did not have managed care in all counties. As you, some of you in the room being from Imperial, you very well know that you were previously a fee-for-service county in managed care. We're adding a couple more in San Diego, of course, a couple more managed care plans, Aetna and United. I think United has gone live and Aetna hasn't started yet. So, my editorial comment here is many years ago when the market was much smaller, we didn't see as much interest in these markets. And we're seeing with the growth and with the ACA, suddenly, the cynic in me and the local plan advocate in me says, everyone is so interested in Medi-Cal managed care, and they're all running to the markets to get a slice of it. So moving in, 7 managed care models. I like to say there's actually 3. This is the department slide. 7 managed care models is in a technical sense. It represents really the advent and how they rolled out separately over time. But you have three basic models of Medi-Cal managed care. And what that means is how many health plans you have in your county. So you have a COES model, County Organized Health System, which I assume most of you know. That means you have one public managed Medi-Cal managed care plan. Then you have a second model. It's the 2-plan model, where you have, as the name suggests, a local plan and a commercial plan. And then finally, here in San Diego and Sacramento, you have what's called a GMC model, Geographic Managed Care, where you have a number of commercial health plans. Those counties have the most health plans. Today we have 10.7 million beneficiaries, like I said, enrolled in Medi-Cal managed care, so a tremendous growth in the market. I can't skip this slide without mentioning Imperial County. So, of course, you recently became managed care, and recent is in relative history in the healthcare context. And it kind of walks and talks like a 2-plan model with my friends there at California Health and Wellness functioning in partnership with the county, somewhat as a local health plan. So if you read my bio, I might have had a little role in that. All right, so now I get to tell you who we are, for those of you who don't know. So, quick show of hands, how many of you in the room at your hospital contract with or have some type of a relationship with a local Medi-Cal managed care health plan? So, for those of you in the front or in the close, that's actually not a lot of people. So I'm glad I have this slide. LHPC. Local Health Plans of California. I always like to start with context because I don't ever assume that everyone knows who local health plans are and what we do in the marketplace, and I think by the show of hands, that illustrates that. Local health plans are the local, as the name suggests, not-for-profit, community-based, quasi-public health plans. And they were formed many of them, a little over 20 years by their communities and really safety net providers to serve the Medi-Cal program. Nearly all local health plans are predominantly Medi-Cal focused. We have LA Care, of course, in the exchange, but by and large, all 16 health plans, public health plans, are in the Medi-Cal line of business. 36 counties, and this is significant. The footprint of Medi-Cal, or the local health plans, is 70% of managed care. So we cover just shy of 8 million of the Medi-Cal beneficiaries in the state of California. It's a significant footprint. Local health plans are among the first, Contra Costa actually, and largest, LA Care, Inland Empire, and Cal Optima, names you all might be familiar with, largest of their kind actually in the entire nation. What's that? Is it Beverly Hills? Badges, we don't need no stinking badges. Anyone seen that movie? Well, then this joke will be lost on you. Go watch the movie. Change is what changes. We're talking about changes in the healthcare system. What changes are we talking about? Again, not just crisis. Let's just do a quick walk down memory lane. Do you all remember the budget crisis from was it 2008 through about 10 or 9? And looking all along that left-hand column, we had the crisis, we had the cuts, and all the litigation, the related benefit restorations. And even today, we're still dealing with the fallout or consequences of that, with some of those benefits just recently being restored back into the Medi-Cal program. I think we forget that we endured that. The other thing I think is important to note here, and we're looking back on those changes we've endured, is when you look at the budget crisis, it would be completely eclipsed by anything brought down by repeal and replace. In the budget crisis, we were able to chip around the edges to save dollars in the program and to keep the program standing. Repeal and replace, there is no way that we can chip around the edges to save the program and keep it in place. You cannot pay for repeal and replace by cutting dental, by cutting podiatry or acupuncture. So that's something that we were reminded of, frankly, in our advocacy this year, that the state budget crises earlier in the decade were absolutely nothing compared to what we would deal with, frankly, in a per capita cap or block transfer environment. Just calling out specifically on these charts other items that you all as hospitals are particularly affected by. Waiver renewals, of course. Public hospital waiver renewal, but also we've seen recently the SUDS waiver, so substance use disorder. I heard that was talked about quite a bit in the last presentations. We have to acknowledge all the change that has brought about. Of course, moving over into the second column, I talked about that a bit. It's not just, these aren't just items on a list, but we have to acknowledge that not only with the expansion of managed care into counties that previously fee-for-service, the expansion of just coverage generally, shifting people from having no coverage to having coverage, the incredible transformation and stress on the delivery system, providers and payers alike that has entailed, and trying to keep up with the growth and the demand and really the promises to consumers that came with that expansion in coverage. That I think we have to acknowledge all that went into that, that there's so much more than just saying, well, we expanded coverage, we expanded service. There's so much more in there. Moving over to the right column, I want to call out a couple of items here that, when we're talking about change looking back and change looking forward, so much about making all this work is about partnership and understanding how the changes impact all of us together and how to implement these changes successfully. We have to talk to each other and we have to do it right. And I think Andy and Bill said it best, where we have to start breaking out of our silos, and I think we're all quite guilty of that. And putting heads down, I think to the credit of everyone, putting your heads down and just getting your work done, but also having to lift your head up and look out on the landscape and see what you're missing. So I want to talk a bit, just really briefly, about the enhanced network adequacy requirements. So this is kind of a sub-issue of the item above it, of the federal Medicaid managed care rule. How many people in here are aware of the new network adequacy requirements coming into play next year? Nobody? So it is only Medi-Cal, but I will tell you, there is tremendous interest in applying these network requirements onto other lines of business as well. So it may not hit you now, but it may later. And I'm looking over to my colleagues over here to see if they're shaking their heads. They're welcome to disagree with me. So what this means, new network requirements came out of a federal rule, one of the biggest Medicaid managed care rules in over 20 years. And what the Fed said is that managed care programs have to have time and distance requirements for their networks, which, as we all know in California, we already have time and distance access requirements in California. So we were ahead of the game there. But the Feds went on to say you have to have them for specialists as well, which I think we all know that, well, from the plan side, we could say, you can require us at the plan to meet access requirements, but that doesn't create new doctors. You can't create new doctors and fill in provider shortages by just requiring plans to have more doctors. That's not the way it works. There's a tremendous pipeline. What you need to know there is in the Medi-Cal program, starting July of 2018, there are new time and distance standards for about 15 categories of specialists. And the specialists were selected based on really how in high demand they are, the volumes they serve. And the time and distance standards are vary based on the type of county you're in. And the counties are separated according to density, to provider and enrollee density. So I think Imperial County, for example, is treated as a rural county. So the time and distance standards are longer. And San Bernardino and Riverside, I think, are treated as small counties because actually they're not dense. Surprisingly, in the discussions, San Diego in density models, you should all know, showed up as dense or not dense? Not dense. Policy staff really didn't like that. They didn't like when the data disagreed with what they really wanted. So San Diego was, of course, treated at the end of the day as a dense county. So it's going to be held to the most stringent time and distance standards. If you want to If you want to learn more about it, look in AB 205. That contains all the details of what those new network adequacy requirements are. And just briefly, I have to acknowledge the tremendous changes coming down in directed payments. So that impacts the hospital fee, of course, and IGTs on the public hospital side. So we have been working very closely with our hospital partners, both public and private, and the Department of Healthcare Services to figure out how are we going to change those payment models to comply with what the federal rules require. And we've been working on that. Actually, we just met last week, slogging through all those details, and I'm sure many of you have been dealing with that as well. So I'm curious, because I want to make sure you're all staying awake. What did I miss? When you think of over the last few years, the huge changes that we've endured, coverage expansion, new benefits, eliminating benefits, cutting budgets, increasing budgets, is there anything else? All right. Looking ahead. So this is my best effort to, clearly not do so well with my iPad in formatting. So I'm really apologize about that. I'm very type A, so it's bothering me seeing it up on the screen now. So areas of focus, quality improvement in my presentations, apparently. So three buckets: integration, data and quality, and accountability. This is just really, this isn't formal, this isn't, but I did run it by a few of my health plan CEOs. This is just bucketing the issues we're working in, and these are the categories that I think that the topics and areas of focus fall in. And frankly, listening to Andy and Bill, I think we're all looking at the same things, and that's really good news. So as it impacts hospitals, looking right back on the presentation before me and what Dr. Curry was talking about, behavioral health integration, absolutely critical. The bifurcated delivery system doesn't work for anybody, but we have to figure out to make it work until it changes. What does that mean? I could not possibly sit here and answer that question. I think in the previous presentation, we touched upon it a bit about what plans are doing to make it work. And this is my opportunity to make a plug. Did you know some plans that are making it work are the local health plans? So I have to call that out. I think that local health plans are particularly situated to help make it work because of their closeness with the county delivery systems. Because remember, so many of the public plans were formed by and with and in partnership with their counties and their safety net providers. So they're all looking very closely at behavioral health. And quite frankly, they talk quite a bit amongst themselves to share best practices. What are you doing? What's working? What's not working? Can you share that with me? I want to do that locally. And what's so great is the unbelievable interest and collaboration amongst the plans. California Children's Services, CCS. So starting in July 2018, we're going to see CCS actually carved in as a managed care benefit in some counties. So what does that mean? Today, of course, CCS is largely a fee-for-service or standalone delivery system outside of managed care. For several COES counties, it will actually be made the responsibility of the COES plan. So it will no longer be a fee-for-service delivery system. And because we know that the Medi-Cal managed care delivery system, it's not a closed system. Just because it's county-based doesn't mean there's walls around the counties. Members go all over the state. If the best children's hospital is way up north, or for the northern plan, way down south, that's where we send the kid. So the integration of CCS does not only, of course, impact those COES counties, Cal Optima in Orange County, Central California Alliance, and Santa Cruz and Monterey and Merced. It impacts the whole state and the hospitals, the children's hospitals in those areas. I'm going to move over to data and quality. Bill talked about encounter data. It is all about the data in Medi-Cal. There are federal dollars attached to data now, and if the state and plans fail to provide good, clean data, there will be fines involved and there will be loss of federal funding. So you can fully expect unbelievable pressure and focus on encounter data. Pay for performance, it was mentioned earlier. There's absolutely a drive here. I think the question is and the need is, how do we align all the pay for performance systems and measures? In Medi-Cal, I think it's driven largely by HEDIS. It depends on the plan. It depends on the county. It depends on the population, the provider. I think fortunately and unfortunately, it is determined locally what works best. But there needs to be, I would acknowledge, tremendous conversation around aligning those, because too many measures is not good for anybody. Audits, audits, audits. We feel your pain at the medical groups. This ties into multiple agencies, multiple requirements, and for you at hospitals or provider groups, if you have X number of contracts, X number of regulators, you're being audited all the time. And at the health plan side, we would say that our state agencies, they don't work together. I've heard anecdotes about state agencies being on site at the same time, and they literally slam doors so that they don't talk to each other, they don't share information. We have had a very successful work group with the Department of Healthcare Services on streamlining audits and audit oversight, because it is a tremendous headache for everybody. Not only for the health plans, but because then the health plans have to turn around and bother their contracting providers whenever the state asks for information. And we've had some really good success with the Department of Healthcare Services trying to streamline and improve that audit process and cut down the duplication between what they do and what the Department of Managed Healthcare does. And then over on accountability, transparency, of course, I think that ties in with encounter data. Everyone wants to know, and everyone wants to have all the data that health plans have. But first, we got to make sure the data is good, and that involves partnership between health plans and all the providers, of course. And then I want to call out as well, and I'm curious what Bill's reaction would be to this, is delegated entities and accountability. I think we can fully anticipate an increased amount of scrutiny and oversight over delegated entities and what's going on in that segment of the delivery system. Lastly, fines and enforcement, no question. You read the headlines. There's been some news this week about some pretty big fines. We saw multi-million-dollar fines a couple months ago that were the first of their kind from the Department of Healthcare Services on the Medi-Cal side. Expect more. Expect more. What's not up here and what's threaded through these? Social determinants of health. And the challenge there is, of course, so much of the focus is on housing, but who pays for it? And that is a tremendous challenge right now. And related to that, and it kind of ties in also with shared savings, is if plans achieve savings by reinvesting in or investing in respite care as opposed to nursing facility care or more acute care. The rate structure in Medi-Cal now says those dollars I save at the health plan, thank you very much from the state, they take those dollars away. We don't get to reinvest them back in the system. So one of our focus this year is to try to revamp that rate process so that savings achieved between your partnerships and your health plans can stay in the system and be reinvested to continually improve the care that you're providing locally. And so that's it.
Thank you. That was a tremendous amount of information. And I know we started a little bit late, but I want to try and keep us on time. We have about 5 to 6 minutes to take some questions for all of you. And so while you're thinking about those questions, raise your hand. And I wanted to try and tie some key themes that I think I heard that really present some opportunities here. I think from the hospital and health system perspective, there's a lot of common areas of priorities that we share in everything from regulatory reform and administrative simplification, when you said less measures, I think everybody would have stood up and clapped for meaningful quality measures. When you think about us moving in this value-based trajectory and thinking about these advanced payment models where we're, some days I know we all say that cliche, we've got one foot in the boat and one foot on the dock, and sometimes I wake up and I said, what happened to the boat? And it's a really challenging in this environment as we think about the trajectory that we're on, and we're having some fits and starts with these advanced payment models here at the federal level, which I know creates some uncertainty. But there's a commitment to that. And so there are some shared principles that I think we all come to the table with. And then, of course, looking to our community partners in addressing the healthcare needs of our patients, working very locally on some really big issues. I heard social determinants of health 3 times in this presentation. Looking outside of our silos and our boxes to think about how we can collaborate together. Not coming to the table with our own set agenda, but thinking about bringing the right people together to have the conversations about setting a shared agenda. And so I think the purpose of our conversations today was to really give you a flavor about some of the priorities of these different organizations and how we might be able to work together. We recently, as an organization at CHA, we were challenged in a team, what would I call it? A team activity. And the whole purpose was communication. I think the activity would have been achieved if each one of us as staff were given the assigned task and did it by ourselves. We would have achieved the goal and everybody would have been successful, but that wasn't the point. The point was you're given a goal and a task, and the goal was to work together as a team with many restrictions, by the way, and I won't go into it, but find me at the break, or Peggy, or anybody here from CHA or the associations to tell you about it. But the hardest part is communication. It's making the time. It's about sitting down and thinking about some of those common priorities and where we have opportunities for challenges, and challenges to address. So I just want to thank each of the panelists for sharing their perspectives, as I know that all of you will return to your community looking for opportunities to work together in what is certainly a significant time of change. So with that, I want to open it up to questions and comments from the audience. And if not, I have several softballs I can lob up here, but we're limited on time. Okay, so I'm gonna lob a softball to the panelists, and I'm just gonna take one. And if there's so much change at the federal level, right? And you are tasked here with trying to anticipate that every day. And translate that into the work that you're doing at the state level. As you think about our state, and as we approach a new waiver in 2019, and we approach this uncertainty here of the Affordable Care Act, and you think about a new administration, both at the state and also at the federal level, how are you thinking about, as organizations, how you position yourselves to either work with the federal or a new administration or agency in thinking through accomplishing your goals? Because we're in this period of change now, but we're going to have more change in light of an election next year here in the state, and then an administration that is clearly committed to making some significant changes at the federal level, in particular in the Medicaid program. So does anyone want to toss out kind of how you're anticipating engaging at both levels?
So what comes to mind is a recollection of our time back in DC this year, where we realized very quickly going into some offices of our delegation that so much education is needed. There is an absolute lack of fundamental understanding about healthcare, about how healthcare works and how delivery systems work, and frankly, how even Medi-Cal works, or Medicaid, and what it is. So I'd say one of the things we're focused on is education, facilitating that understanding, and touting the successes, frankly, of the program and all the wonderful things that it does, both federally, at the federal level and the state level.
Just to add on to that, I will say we learned a lot. I mean, California is blue, and the association leans blue in our statements. So we learned quickly, I think all the stuff that was coming out at the beginning we wanted to have really powerful statements about it, and learned that by doing so, you might lose access to meetings that you really wanted to have. So that was a helpful, painful a little bit, but helpful in trying. And so it's this really fascinating position to be in about principles, and then continuing the movement and how not to lose your integrity and to continue to stand for what you believe in, but to do so. And it was interesting to read Seema Verma's comments at I think it was at the NAMD meeting that she was doing it, where and everything that she was saying about what her goals are, I thought that's exactly what our goals are. Yeah, we want to lift people out of poverty. We want to empower all of these individuals. We want to have a stronger, more streamlined system. We're always first to say there's too much regulation and we can't report all of this. We just have such a different approach in how to get there. But I think it's so important to hone in on the goal, because that is the goal. And I think it's interesting. When I was listening to Brianna talk about the 3-plan model, intellectually, I bet if we had written it from a policy perspective, we would have said from an economics that the county or the geographic managed care, that's the best one. They're going to just compete, the best prices, it's going to be awesome. And when all of our health centers would say, please get us out of geographic managed care. It's the worst thing that's ever happened. It's way too confusing. And we hear a lot from our partnership health centers, it's the best model that's ever existed. Please only give us one health plan, which from a policy perspective and voters, you'd say that's a terrible model. So I think it's interesting that what it makes me think about is that we at least at the health centers, we have a way of thinking, as everybody usually does. But there might be a different model that actually gets you further along to the goal that you actually want, that isn't the way that you would have constructed it because of your principles. So to me, it's an opportunity to continue to think outside of the box, and movement happens by working together. So we're not going to stay so principled that we're going to close access. But I think to Brianna's point on education, we just all have to continue to keep talking, to keep educating each other, and that there is a way to move forward so long as we focus on the end goal.
I'm a bigger fan of the armed rebellion model, but what are you going to do? What Brianna said is really critical here. What we've seen since 2006 when we started going to DC and lobbying, you have to educate. And I think one of the interesting things that we've noticed is that there's a tremendous interest among members of Congress on the East Coast to come back to California and see how we do things. Tom Carper, senior senator from Delaware, is an example who's been out to 2 of our groups, Brandon Toland in San Francisco and Sharp Healthcare here in San Diego. Comes out on his own, no entourage, and spends a few hours just talking and learning and listening. Of course, Ron Wyden, fantastic, has been down here a number of times to talk to us. Greg Waldron, chair of Energy and Commerce, congressional member from Eastern Oregon, a Republican, very interested still to listen and learn. So we're trying to educate. I think the critical area here that we need to focus on, because of the tremendous role of Medicaid now, is that we have got to educate the other side of CMS, the Medicaid side of CMS, to understand what the other side of the aisle on CMS does in Medicare. So that staff, Brianna mentioned delegation. Delegation has been a huge issue in the expansion of Medi-Cal managed care in California. And one side of CMS does not understand how delegation occurs on the other side in Medicare Advantage. And we've had a tremendous amount of problems with the expansion in California just because CMS staff has dug so deeply into how local health plans would construct their delivery systems for the duals expansion, for example. When these same organizations are generating 4.5 stars on the MA side in the very same counties. So a little trust would be welcome, but anyway, I don't want to take up too much time.
Thank you so much for that. I can't let that go without you guys teed me up perfectly. The California Congressional Action Program, Come and Educate Your Legislatures, is in May of next year, May 6th, 7th, and 8th. Do we have time for one more question? Are any of the panelists aware of examples of social determinants of health being integrated in the EHRs?
It is. I was just having to think about it. So the National Association of Community Health Centers, our national partner, created what we refer to as PREPARE, and I will not attempt to know what the acronym stands for, but it was the attempt to standardize one format for how health centers could capture social determinants of health, and they worked with all the major EMR vendors to create templates so that it is now integrated into the electronic medical records. We've been working on a pilot with them, with a subset, San Diego's involved in this, on how to do that better. I'm not involved in that level of detail. Perhaps Vernita and Kevin are. But it's our attempt to just figure out how to track it. And I'm sure you have the same conversations about standardization. Not every health center wants to use Prepare because they have their own reasons why, but we are at the state level, because it is helpful to have a standard model and a standard set of questions. We are really supportive of this one. And so far, hearing that it's really making some inroads in having a process. I don't know how they're actually what they're doing with the data at this point, but there are, because it's national, this pilot, there's thousands and thousands of Medicaid lives and uninsured lives in this data set that they're looking at.
Great, thank you. I apologize, I ran over, but thank you for the indulgence of a little bit of more of your time. Please join me in thanking the panel.